All right, everyone, welcome. As you get ready to start your clerkships, what we're going to do today is build a really solid clinical framework for treating type 2 diabetes. The goal? To give you something you can actually take with you and use the minute you step onto the wards.
So here's our game plan. We'll kick things off with the big picture shift in how we think about this disease. Then we'll lay down the foundation of therapy, and after that, we'll walk step by step through the modern approach to picking the right drug for the right patient.
Okay, let's dive right in. For decades, the main goal in type 2 diabetes was pretty much all about one thing, getting that A1C number down. But what we've learned is that just chasing the A1C isn't enough, because this is a super complex disease that affects multiple organ systems.
And this slide, it just lays it all out perfectly. This is not just a pancreas problem. You've got the liver making too much glucose, you've got muscles that aren't taking it up properly, and you've got kidneys that are reabsorbing way too much sugar. Our modern therapies are so cool because they're designed to hit these specific problems, which is, a way more sophisticated approach than we've ever had.
So, you've just made the diagnosis of type 2 diabetes for your patient. Now what? Where do you even begin? Well, the answer is almost always the same. Unless there's a good reason not to, therapy starts with intensive lifestyle changes and our anchor drug, metformin.
Now, this slide basically gives you all the high-yield facts you need for your pocket. Its main job is to stop the liver from pumping out so much glucose. It works really well, it's weight neutral, it's incredibly cheap, and, this is huge, we have data showing it reduces the risk of cardiovascular events. Now, the clinical pearl here is absolutely key. You have to start with a low dose and increase it slowly. That's how you avoid the GI side effects. Metformin is the foundation. It's where we start. But here's the thing about type 2 diabetes. It's a progressive disease. So for most of your patients, they're eventually going to need a second medication. And this right here, this is the decision point where modern diabetes care really begins, and it's where you can make a massive impact. So your patient's on metformin, their A1C is still not at goal. What's the next move? Well, the first question you've got to ask yourself is no longer, how do I get that A1C down? Nope. The real question, the modern question is, does my patient have high-risk heart or kidney disease? Think of this flowchart as your roadmap for the rest of this talk. And notice the key takeaway at the very bottom. Assess the heart and kidneys first. Their status is what dictates your next drug choice, and it often matters more than the A1C itself. This is the paradigm shift. So let's follow these two main paths, and we'll start with a high-risk patient over on the left. All right, so let's head down that left side of the flowchart, the high-risk path. For any patient who has established cardiovascular disease or heart failure or chronic kidney disease, our choice is now driven by one thing, protecting those organs. And this is true no matter what their A1C is when they start. First up, we've got the SGLT2 inhibitors, also known as the Flozins. They work in a pretty cool way. They block glucose from being reabsorbed in the kidney, which means patients basically pee out the extra sugar. But here's the essential clinical pearl. I want you to think of these as heart and kidney drugs that just happen to also lower blood sugar. We have powerful, proven data that they reduce hospitalizations for heart failure and they slow down the progression of diabetic kidney disease. Your other powerhouse option for these high-risk patients is the GLP-1 receptor agonist class. Now, these are injectables that act like our own natural incretin hormones, and these drugs are absolute heavy lifters. They're great for lowering A1C, they're fantastic for weight loss, and they're proven to reduce the risk of stroke and heart attacks, a true metabolic game changer. Okay, so that's the high-risk patient, but let's rewind and go back to our flowchart. What about the other path? What about the patient who's on metformin, their A1C is still high, but they do not have those high-risk heart or kidney conditions? For these patients, our priorities shift. The game plan changes. We're still treating their glucose, of course, but the choice of the next drug really comes down to a few other critical, patient-specific things. We're mainly focused on minimizing the risk of hypoglycemia, trying to promote weight loss, and thinking about the cost of the medicine. So if cost is the number one issue, you are absolutely going to see sulfonylureas used on the wards. They work by telling the pancreas to squeeze out more insulin. And they're effective and very cheap. But, and this is a big but, here's the major trade-off. They come with a high risk of causing hypoglycemia or low blood sugar, and they tend to cause weight gain. That is a huge clinical consideration. On the other hand, let's say your main priority is avoiding hypoglycemia. Maybe you have an older patient or someone who's a bit more frail. In that case, the DPP-4 inhibitors, the gliptins, are an excellent choice. They're pills, they're weight neutral, and people tolerate them extremely well. The downside? They don't lower A1C quite as much, and they cost more, but that safety profile is often worth it in the right person. So let's just put them side by side. The choice between these two often boils down to this very clear trade-off. It's a conversation you'll have with your patient. Are we prioritizing the low cost, but accepting the risks of low blood sugar and weight gain with a sulfonylurea? Or are we prioritizing safety from hypoglycemia and accepting a higher cost and a little less potency with a DPP-4 inhibitor?
And of course, we can't forget about insulin. Remember, as the beta cells in the pancreas get tired out over time, many patients with type 2 diabetes will eventually need it. It is still our most powerful tool for lowering blood sugar, and it's what we turn to when the A1C is really high or when other combinations of drugs just aren't getting the job done.
Okay, wow. We have covered a ton of ground, right? From the deep pathophysiology all the way to this brand new clinical framework. So now let's boil all of this down into a practical tool that you can carry in your mind, or maybe in your pocket, when you start your rotations.
Look, if there is only one thing you walk out of here remembering today, I want it to be this. This philosophy is the absolute heart of modern diabetes care. It's about looking at the whole person sitting in front of you, not just their latest lab value.
And this table, this is it. This is your cheat sheet. It neatly summarizes all the key clinical decision points for every major class of medication we talked about. This is the practical, high-yield takeaway I want you to have for your very first day on the wards when your attending asks you what you want to do next for your patient with diabetes.
So as you get ready to step onto the wards, your job is no longer just about lowering a number. Your job is to embrace this patient-centered, comorbidity-driven approach, because that is how you will truly improve outcomes, and that is how you're going to provide the best possible care for your future patients.